will allow people to play it back. And the recording has now commenced. So I'll just make sure it's working fully and formally welcome everyone to this meeting. And just by way of explanation again, we make this meeting available after it's been transmitted live so that people can watch it back. And we do find that's really helpful for many people who do find that useful. And there's a good rate of watching back last year. So anyway, without further ado, I'm delighted to open this meeting. My name is Krishni Waring. I'm the chair of Northamptonshire Healthcare NHS Foundation Trust, and I'm really pleased that you've been able to join us today. I think Tracy probably move on to the next slide, or Matt, just making sure that we've got our slides running. So that's me, and as I say, delighted that you're here. If we move on to slide 3, please. So just to share with you what we've got in store for you in this session. It's a packed agenda. I really hope that all of you who've been kind enough to join us at this session find it a really helpful and enjoyable session. Obviously, we're going to take a chance to look back on last year. That's what our AGM and annual public members meeting is all about. There's some great case studies, as you can see. You'll be hearing from our Chief Executive, Angela Hillary, and other colleagues as well about a number of things we've done, and particularly services who are involved in delivery of care for us. We've also got a case study on Together Against Racism programme of work that we're doing with our group model partner, Leicestershire Partnership NHS Trust. We're also going to be hearing from our auditors, and I think that's a really important opportunity to make sure that members of the public and members of staff and other colleagues, our governors, actually can demonstrate to you our public accountability and transparency around what we're doing. And of course, much of this session has been organised with the support and help of our governors, who are a key part of the governance of our organisation. And there'll be a session, a video actually from our governors, many of whom I know are with us today, alongside members of the board. So that's a quick overview of the agenda we have planned for you today. And I do want to mention we're going to be using something called Slido, which I think we'll explain shortly as to how that's used. But we're going to be using that technology, that tool, to collect your questions and comments. And we really encourage you to submit those, because it's a great opportunity to interact and get some questions answered. So there's going to be an opportunity to scan, I think, a QR code, which just to clarify, Matt, have we already shared that QR code? Are you able to confirm that? Yes. There we go. So we've got the QR code, and you can, if you're not familiar with that, you can just hold up your camera, and that will take you to the Slido question and platform that will take you through the various opportunities you have to comment and answer and ask any questions. Now, particularly wanted to draw your attention to the minutes of our annual general meeting of the Council of Governors and the annual public and members meeting from last year, 2023. The minutes have been available on our website, and we've asked people to comment leave any comments via Slido already. So I just want to double check that whether there are any comments that we need to share with you for the purposes of noting as far as the minutes from last year are concerned. So Richard Smith, are you able to confirm whether there are any comments?
Thanks, Krishni. Good evening, everybody. No, we haven't had any comments back on the minutes. Thank you.
Great. Thank you, Richard. So we'll take it as that the minutes are approved from 2023. So we will be opening up Slido, as I've already mentioned, for your questions this evening. So the opportunity will be available all throughout the session, right up unto, I think, the case study on the memory assessment service. It will be available for you to submit your comments and questions, and we will obviously try and answer as many of those as we can through the course of the session. We have actually received a number already, so we will be trying to respond to as many of those as we can. What I would like to say is obviously what we can't do is respond to questions about individual concerns or particularly ones around patient care that is specific to an individual patient, obviously for privacy reasons as well. So we would ask that those are submitted through our normal patient liaison service. And indeed, other sort of very specific HR questions are also difficult to answer. But anything else that's more broadly, we'd absolutely welcome those, and we'll answer as many of those as possible. So hopefully everyone will be able to work with that. That's really everything I wanted to cover in my introduction. So I'm really delighted because we're going to start our formal review of 23-24 by introducing our Chief Executive, Angela Hillary, who's going to take you through that. So over to you, Angela.
Thank you, Krishni. Hello, everybody. As Krishni said, my name is Angela Hillary. I'm delighted to be here tonight, and can I thank you for joining us here today to reflect with us on our year 23-24. I'll clearly be speaking through some of the key highlights, but I would encourage you to read our annual report and accounts for more information on our year, because it contains so much more information. As you will see, our theme for this year's meeting is making a difference across the generations. This is to reflect the amazing work that's done on all NHFT colleagues who support patients, service users from birth throughout their lives with both physical and mental health challenges, and that's through to end-of-life care. This theme will be reflected in our speakers you'll hear from later too, and there'll be colleagues who'll be sharing with you how they're working with children and young people, and you'll hear from a team who are working to support older people with dementia and memory impairment. One of the examples of working across the generations is at St Mary's Hospital. This was at one time a maternity unit, and we now have colleagues such as Michelle Jones, pictured there, who was born at St Mary's Hospital and is now a familiar face working with us on the reception there. And as we see across the organisation, we have many of our teams being both colleagues as well as current or former service users, carers, and of course members of our wider community. In our annual report in 23-24, you will see reflected on the priorities for the year. The year has certainly given us and presented many external challenges: the ripple effect of a global pandemic, cost of living crisis, and continued health inequalities. This with rising costs, demand for services, and ongoing resource challenges. And we must remain fit for the future. Limits to resources mean we have to think long and hard about what value is to NHFT, and I will touch on this again later. We will always prioritise safety and strive for outcomes over costs, and this year we've been working hard to empower our colleagues, innovate in all of our services. You'll see lots of names here, and during the year we renewed our focus on ensuring we're providing compassionate, safe care for our community. And as part of our commitment to being a compassionate trust, in the summer of 23, we launched our new monthly recognition programme for all our staff to be compassion champions. This was open to all colleagues to nominate, and the programme showcases colleagues and teams who've shown compassion to colleagues, service users and carers. We're very proud of our people here at NHFT. They all go above and beyond, and wanted to share that with you and celebrate their commitments here. Thank you to each and every one of them. And we can see compassion in action in our services in so many areas. For example, we're expanding the Carer Peer Support Workers initiative so we can provide peer support and resources while waiting. We've enhanced our support services. For example, the Serenity Sexual Assault Referral Centre, SARC, unveiled a refurbished family room, and thanks to our generous donations from the Northamptonshire Health Charity. This renovated space is designed to provide comfort and support to individuals and families experiencing trauma. And we also launched the Menopause Care in Custody initiative in partnership with our local police custody services here in Northamptonshire. And this innovative programme offers support to women experiencing menopause symptoms whilst in custody. Compassionate care is all about understanding someone's experience of our trust. And it's important that we listen to this feedback and ensure that we are continually improving. And some examples of our feedback include our community mental health teams, who've significantly increased the review numbers by using SMS texts to make sure that we get systematic requests and feedback, and now have a clear understanding of both positive and negative themes from this. Turn Furlong is one of our units where we look at recovery, and we've embraced the patient feedback system the Trust uses as a primary means of feedback to serve the needs of not only ourselves here at NHFT, but also West Northamptonshire Council. And HMP Peterborough appointed a patient experience lead to encourage residents to provide feedback and to work with residents to improve the experience of prison health services overall. Now, I've mentioned value in healthcare. It does not mean saving money at any cost, particularly in the health and social care context. It means delivering the highest quality, safety, and most efficiently. And we know it's important to keep pushing forwards and driving change through our value programme. We continue to transform, expand our community teams to improve access to care and support the system to deliver increased levels of care in our communities. We are focused on reducing the length of stay in our health and care settings so that patients can regain their independence wherever this is possible. You'll also hear in one of our case studies the transformation we've seen in memory assessment clinics, which both provide value in healthcare and a better experience for our service users too. The healthcare staff at HMP Bedford have introduced telephone reminders to patients for GP appointments, and this reduces non-attendance and reduces waiting lists caused by missed appointments. And nationally, we've been working to support the reduction of the use of agency in our agency workers. This has been made possible by our thriving staff bank, and we are very proud to have them as part of our team NHFT. Looking to the future, we continue to transition and transform to more innovative models, and innovation goes hand in hand with the value I've described and the partnership working. In the last year, we have launched our innovative crisis response unit, which provides rapid crisis support in a mental health emergency. Our sexual health services have been piloting the use of a machine to allow results to be available to patients within 24 hours. And they've recruited administrators as part of a drive to increase opening times. Our remote monitoring project, developed in collaboration with system partners, was shortlisted for 3 categories at the HSJ Digital Awards, and it was implemented as part of Integrated Care Northamptonshire's Ageing Well colleagues to pitch innovative ideas and receive funding to implement the WELL programme. This initiative uses healthcare technology to enhance care delivery across 11 care homes, and there's more to follow. We've also had partnership working for our inclusion of neurodiversity in schools, and it means we can work together with system partners to create environments that better meet neurodiverse children's needs. The Northamptonshire Anchor Institutions Network was launched, a network that aims to tackle social and economic disparities in the region through collaborative efforts among 23 member organisations of which we are a part. And we've also launched our Dragon's Den project led by our medical director, which allows any colleague to pitch an innovative idea that improves the care that we are providing. And in addition, and last but no means least, we continue to work in partnership and innovate through our group model with Leicestershire Partnership Trust and the East Midlands Alliance, which works with all mental health providers in the East Midlands. So reflecting on our need to continually innovate, move forward and progress, we're developing a new strategy. And this will replace our current strategy, Digby Q, which was based around developing, innovating, growing, building with quality and safety at the foundation of all we do. But this new strategy will focus our group on what we need to prioritise over the next few years. And it's essential that we're prioritising what's important to you, our people. That's you, NHFT colleagues, our service users, carers, families, communities and stakeholders. It's really important that we hear from you. We want to. What's important to you is what's important to us. And this will help us to shape and develop our new strategy. And it will be a strategy for the entire NHFT community. So please take time to complete the survey. Let us know what's important to you. You can either use the QR code or click on the link on these slides, which will be shared after tonight's meeting. And finally, a big thank you from me. I want to say a big thank you to everyone. You can see, I hope already, that we've had tremendous support throughout this last year, and so many of you have given us that. But a special thanks to our health charity partners and everyone who supported us here at NHFT. I really cannot thank you enough, and I look forward to continuing our work together in 24-25. Thank you.
Thank you very much, Angela, and colleagues, anybody observing, if you'd like to ask any questions prompted by Angela's presentation, please do submit them through Slido, as I've mentioned. We obviously would love to answer as many of those as possible. So I'm delighted now to take the opportunity to introduce our first case study for this evening, which is actually all about our CAMS service, Child and Adolescent Mental Health Services. And I'm particularly pleased to welcome Marie James, who is going to be leading this presentation. And hopefully, Marie, you are here in order to take that forward.
I am, yes. Good evening, everybody. Okay, if we could go to the next slide, please. My name is Marie James and I'm the Service Manager for CAMS Crisis, CAMS Intensive Outreach Team, CAMS Inpatients and the Residential Short Break Service. So I first wanted to kind of start off by telling you a little bit about the Provider Collaborative and what it is. So Northamptonshire Healthcare Foundation Trust is the lead provider for the East Midlands Provider Collaborative. And that's a group of provider services like us at NHFT, but across the East Midlands. So it includes Lincolnshire, Leicester, St Andrews, Nottingham, Derby and Chesterfield. And the East Midlands Provider Collab has a central referring system. So all children and young people that need admission to CAMS inpatients come through this central system if they need an inpatient bed. There's also a team that complete access assessments for each referral. So that's working out whether the admission is appropriate or not and exploring if we've exhausted all that we can offer to help young people out in the community so that they don't come into hospital if they don't need to. There is a central waiting list so that everybody across the collaborative has an equal wait time or not if there is beds available, and that is the same for everybody across the whole collaborative. Next slide, please. So I wanted to kind of give you a bit of context as to how you would end up needing to be referred to an inpatient bed and tell you a little bit about what exists in the community already. So the East Midlands Provider Collaborative also commissions a CAMS intensive outreach team. So the aims of that team are to avoid admission into CAMS inpatients, to offer a bespoke package of care in the community, to reduce the need for out-of-area admissions, so young people going far away from home, and to offer step down, so when young people have been in hospital, they're given the support they need on discharge, and that hopefully would stop them needing to come back in. The CAMHS crisis team are the gatekeepers for the CAMHS intensive outreach team. So when you've exhausted what's on offer in the CAMHS crisis team, they would refer through to the CAMHS intensive outreach team. And the intensive outreach team is a multidisciplinary team. So they've got all different professions: psychiatry, nurses, support workers, dietitians, OTs, psychologists. And the package of care is basically based around what the young person needs, and it's within their family home. The team can come up to 3 times a day, and they have the same training as CAMHS inpatient staff, and that includes nasogastric tube feeding and positive behaviour support. Next slide, please. The CAMHS crisis team is slightly different. They provide a fast response to children and young people with moderate to severe mental health difficulties, experiencing an acute deterioration in their mental health and an increase in risk. They offer a more brief intervention for children and young people that have been clinically assessed as needing intensive support to maintain their safety in the community. They operate a 24/7 clinically manned telephone line similar to adults, and parents and carers and children and young people can access that advice in relation to their mental health. They also offer a self-harm pathway, which means that they offer self-harm assessments in our local acute hospitals, Northampton and Kettering. And they also accept direct referrals from the wellbeing cafes. They're also a multidisciplinary team. They have nurses, social workers, family support workers, non-medical prescribers, carer peer support workers, and psychological therapists. And as I said, they are the gatekeepers for the CAMHS intensive outreach team and CAMHS inpatients. Next slide, please. And just to kind of add to our pathway, we also have the wellbeing cafes, which is a drop-in service for children and young people. We now have 9 cafes operating across Northamptonshire 6 days a week from Monday to Saturday, and they offer immediate support without the need for any referral. And that's a collaboration between ourselves and a third sector counselling service, Reach Collaborative and St Andrews Healthcare. And that was a co-produced service model that we produce with young people in full consultation. The cafe has a staffing structure of qualified counsellors, skilled HCAs and volunteers. And we are the lead provider, so we provide the training for the staff in the cafes. They have direct access to the CAMHS crisis teams. If there was any cases they weren't sure about or any children, young people that needed additional support, they can refer straight in. And they can also support young people to access referrals into their own youth counselling services and offer signposting and support. And they can also support parents and carers, which is really helpful. Next slide, please. So I am here to tell you about Liv's story. And Liv was a young person that came into the Burrows. Bear with me just a second while I make sure I've got the right presentation up. Okay. Okay, so Liv was 12 years old when she was initially referred into NHFT school nursing by her school. She'd lost a lot of weight and her general mood and presentation had dipped. Following a school nursing intervention, Liv continued to deteriorate and was referred into the community eating disorder team. The community eating disorder team offered family-based treatment and referred into core CAMHS for support with an obsessive compulsive disorder type presentation. Despite the package in the community, Liv continued to deteriorate with severe food restriction, drinking excessive water, and there was also physical aggression towards mum, and Liv was harming herself. The community eating disorder team referred Liv into CAMHS inpatients for under 13 years. This is provided quite differently to the provider collaborative in the East Midlands, and the Children's Network manage our children's inpatient beds. Liv went into General Hospital to wait for her admission and was offered a bed in Liverpool in an under 13s ward, at which point her weight was 34.1 kilogram. Liv was in the under 13s hospital from February 2023 through to July 2023. She was diagnosed with anorexia nervosa during her admission. Liv was allocated a case manager from the provider collaborative with a role to quality assure her journey through CAMHS inpatients. She attended all of Liv's meetings and would have regular communication with the ward regarding her presentation. By July, it became apparent that Liv would not be ready for discharge before her 13th birthday in September. and so Liv was referred into Northamptonshire CAMS inpatients for access assessment. The provider collaborative played a vital role in the referral process. The case manager met with the service manager and ward manager to discuss Liv's case and advocate for her. It was clear that Liv had a very complex presentation and careful consideration was needed to a more bespoke package. At the point of referral, Liv was detained under Section 3 of the Mental Health Act. She was not taking any oral food and required feeding under restraint using a nasogastric tube. This was delivered by a team of staff who needed to wear protective clothing. Livy spent time in seclusion for aggression towards staff. Her self-harm had increased, with the risk to herself being significant. She was refusing all medication and was also requiring periods of time in extra care. Other than weight restoration, which Livy had managed to increase weight to 40.6 kilograms, Livy had not made any progress towards discharge. She wasn't accessing home leave or leaving the ward. The Burrows, which is a 10-bed CAMS inpatient ward on the Berrywood site, completed Liv's access assessment. She was access assessed as requiring a paediatric intensive care CAMS bed due to the level of aggression towards staff, the level of restraint required, and the daily seclusion. The nearest paediatric intensive care bed to Northampton is Nottingham. Liv had just had an extensive admission far away from home in Liverpool. Considering the lack of options and the possible poor outcomes of her being far away from home, the Burrows agreed to consider Liv for admission if they could be supported by the provider collaborative using an extra package of care, which is where additional resources are offered. This allowed the Burrows to provide the additional staffing that Liv would need, reduce the bed numbers, and ensure that there was available space should Liv need a reduced stimulation environment. When Liv came onto the Burrows, it became evident that she needed a very high level of support, especially around feeding. She continued to refuse all oral nutrition. Despite the Burrows having extensive experience in nasogastric feeding, Liv's feed was extremely difficult for both her and staff. 10 members of staff were required to safely feed using a restraint technique and safety pod. Liv would become highly distressed. The dietitian worked with the team to enable the team to do 1 feed per day to reduce the distress this would cause for her. She could be distressed for up to 2 hours after each feed, where she would be targeting staff throughout that time. Liv's risk assessment and care plan needed review and update daily. The team needed to positive risk take and think creatively. The risks pushed the boundaries of many of our trust policies, especially around manual handling, as the only way to safely feed Liv was to lift her into a safety pod. We had multiple escalation meetings to discuss the level of risk. We watched hours of body-worn camera footage to perfect the restraint intervention and to try and protect Liv and staff on disengaging. Staff were significantly injured during restraints on a daily basis. Staff needed high levels of support and supervision. We also purchased protective equipment to try and prevent some of the injuries. Outside of feeding, Liv was able to engage in some of the programme on the ward. She was able to build up some leave and access some of the activities. Prior to admission, Liv refused most personal care, brushing teeth, showers, etc. Through a period of assessment, Liv's clinical team queried if she may be neurodivergent and introduced some activities and techniques to support her. Liv was very reluctant to engage in the support offered, especially the therapeutic support, but did engage with some key senior nurses who had experience in autism and learning disability, and they were able to offer some one-to-one sessions. Liv also accessed medication and was regularly reviewed by the ward consultant. The ward consultant was also very, very flexible with her leave and enabled Liv to start re-engaging with the community outside of a hospital setting, despite the levels of risk that she was presented with. The rest of the trust played an absolute vital role in supporting the ward to manage Liv and to support the staff. The personal safety team played a vital role in helping the ward to safely manage Liv. The manual handling team came into the ward to support with care planning. Adult mental health services supported by helping with staffing and cover, And the senior management team and leadership team were absolutely brilliant and very visual to the ward, going and often checking in, and that went right up to the chief exec. 6 months into Liv's submission, there was a real deterioration in her presentation. Her risk increased to self and others. The feed became more challenging and again required up to 10 staff. The boroughs were really struggling, the staff team was exhausted, and the impact on the ward was really significant. Liv was stuck in a similar position as before, more weight restored but not making any progress. The team made the very difficult decision to refer Liv to a low secure unit, accepting that she may need a different approach over a longer period of time. Liv was accepted to St Andrew's Hospital, but there was a delay in when they would be able to accept her. May 2024 was a real turning point for Liv. She voices to staff that she felt like eating something orally. Staff supported her to do this and absolutely grabbed out at the opportunity. And over the coming weeks, Liv really started to improve. Liv no longer required restraint feeding. She started eating and drinking orally, and the risk significantly reduced. She engaged with a discharge plan, started to go on home leave, and then had some overnight stays. The boroughs worked with Liv to be able to accept help with all aspects of personal care, personal hygiene. Liv accessed a dentist, and she hadn't brushed her teeth or been to the dentist in over 2 years. The boroughs referred Liv into the CAMHS Intensive Outreach Team, which, as I've explained, is also funded by the Provider Collaborative, and they were able to work intensively with Liv at home. The team came to visit her on the ward to get to know her. The boroughs have worked tirelessly to ensure everything is in place for discharge, promoting and completing a Section 117 aftercare plan and negotiating a bespoke crisis plan. The borough's manager went to panel, and 30 hours a week of care was approved through social services. Liv engaged with the ward psychologist and family therapist. Liv was discharged from the boroughs on the 30th of July. She has a stable weight of 55 kilograms and is fully engaging with her community support plan. I'm just going to share some feedback from our Provider Collaborative case manager, who said one of the biggest strengths of the boroughs team is their ability to see their patients as young people first and foremost. Throughout her admission, the team remained entirely committed to supporting her in her recovery. In spite of the very high risk to themselves, the team's gentle and sensitive approach never changed. They remained compassionate and thoughtful, taking a dynamic and positive risk approach. I cannot think of a single other team that we work alongside in the East Midlands who would permit a child to attend one of her hobbies or interests in the local area on the same day that a 10-person team is required to deliver an intervention. Such is the personalised, dynamic approach taken by the team. In their care of her, the physical and emotional toll on the team was high, yet they managed to hold on to hope for her future beyond hospital and showed incredible resilience. There is no doubt that every single person played a part in her recovery, but a special mention must go to the frontline nursing and healthcare support staff, led so effectively and compassionately by Sinead as ward matron. Her visible presence on the ward and reciprocal respect between her and her team makes a difference every day. And just a message from Livy's mum: to have such brilliant, caring, compassionate team around her, celebrating every little win just like I do, means everything. I can't thank you all enough for what you have done for me and my daughter. When I thought my daughter was going to St Andrews, I thought I lost her forever. I have to relearn who my daughter is and how to be her mum. Just a second. I think next, is that the last slide? One more. Yes, so I've just included some slides in the presentation on some feedback around the intensive outreach teams. We've just done an evaluation, but I'm running out of time, so I'll let you all look at those in your own time, if that's okay, because I don't want to eat into anyone else's presentation. Thank you very much, everybody.
Marie, thank you so much. I mean, we had the privilege of hearing you talk to us about that experience at the board, and it was, you know, really inspiring to hear that story and hear about the care that was given to Liv. So thank you again for sharing it. Thank you to all the colleagues who were involved in supporting Liv. You know, and yeah, fantastic work, and we really hope that Liv continues to do well. Just a reminder that if you have any questions about that case study or services more broadly, because obviously we wouldn't want to talk about the individual case in detail, but just more broadly, if that's prompted any questions for you, just a reminder really that you are able to use Slido to ask any questions that you'd like to regarding that case study. Without further ado, then I'm going to move us on to a session or a presentation from our Council of Governors. So the Council of Governors play a key role in the governance of the organisation, and also in making sure, as they represent members of the public, patients and carers in our community, that our board and our organisation remains openly accountable to the community. So they play a really important part. And the governors take a role in gathering the views of trust members. Hopefully there will be members present here today who are listening to this AGM, and it's all about trying to give a voice to our community and the people they represent within our organisation and through the governance. So I'm really pleased that we have a video which takes us through the achievements of the governors and the things they've been doing to hopefully illustrate for you how governors are involved in our organisation. So I'll hand over now to Matt to hopefully press play on the video, and we'll look forward to hearing that. Thank you.
One key theme from the Northamptonshire Healthcare NHS Foundation Trust Annual Effectiveness Review was that governors often struggled to understand how to undertake their role in practice. Embracing this challenge in summer 2023, the Trust asked their governors to make pledges relating to their contribution to the work of the Council for 2023-2024. The pledges aligned to the governor's statutory duties of holding the non-executive directors to account and representing the interests of members and the wider public. So the pledges offered a chance to refocus on the core parts of the governor role. The Trust issued governors a pledge list that they could choose from, to which they could also add in their own ideas. The finalised list gave governors lots of day-to-day examples of undertaking their role and inspired and supported the governors to take ownership of their contribution. The pledges included attending specific meetings, actively contributing to member communications and observing service visits with non-executive directors or board meetings. 19 governors made 100 pledges, which was a big win for the Trust. 17 of them started working on their pledges, and they regularly shared updates with the Council of Governors, keeping everyone inspired. The pledges have enabled governors to plan how they individually contribute to supporting the overall Council of Governors in fulfilling their statutory duties, recognising the diversity of perspectives among them. This success is evident in the abundant positive feedback received from governors, fostering a strong sense of unity among council members. Now governors are equipped with the knowledge to enhance engagement, meet their responsibilities, and embrace new opportunities via their pledges.
So my name is Richard Amponsa, and I've been a governor since May 2021, and I've worked for the Trust since February 2006. The reason I was interested in becoming a governor is because I wanted to understand the role that governors play. I had always known that we had governors, as part of our foundation trust, but I didn't really understand what they did and how they helped contribute to the trust's, the achievements of the trust's objectives. So being a governor for me was to understand more of their role and how I could personally contribute to help them fulfill that role. So that's why I became a governor.
I'm Carol Phillips and I'm a carer governor, but I've been a public governor for 6 years before that. I became a governor in the beginning because I wanted to give something back to the community, and I wanted to be a bridge between the community that I represented and now represent and the NHS in the form of NHFT.
My name is Heba Kadia. I am one of the trust governor. I have applied for this post to voice our staff concern and to give them a little bit of safe space to raise a concern to our trust, and to attend joint council of the governor, and as well to attend the trust events such as opening day, speech, to recruit more new members, and as well to observe the board of directors meeting and provide feedback on consideration for governors, and as well to take part of interviews such as stakeholder panels.
One of the reasons why I considered joining the NHFT as a governor was I wanted to put something back into the system, and I wanted to engage with the local community, but also take their concerns up through the chain of command to get them listened to.
It made me understand the expectation that there was, and also it meant that I could make the commitment that suited my situation. So as a carer, for example, I'm not able to go to very many face-to-face meetings, but I can contribute virtually through virtual meetings. So I think that helped me to understand what I could commit.
But making the pledges is a way of helping to focus the mind in terms of what specifically you're trying to achieve. It gives me kind of measurable, achievable targets to focus on, and so that's why I think it was important for me to make my pledge, because it helped me to focus on what I was trying to do, and how in a way that I was able to kind of quantify how my contribution was making a difference.
I think it's very relevant for governors to make pledges because it allows us to understand a little bit more about what our community requires, but also what the NHFT is trying to do within the community. So pledging gives us a sense of responsibility to ensure that we actually follow through in what we say we're going to do.
Well, because of my role as a carer, I concentrated on pledging to attend virtual meetings rather than face-to-face meetings. And one of the most important of those is that I chair the Nominations and Remuneration Committee of the Council of Governors. This is important in terms of holding the trust to account, because we are responsible for the appraisal of the chair and the NEDs, and also in terms of appointing the chair and the non-exec directors.
Is to attend or observe the non-exec service visits to the wards, and as well to give safe space to our staff to make their voice heard, and as well put the non-executive into account, and as well to help create links with communities group, face group, and attending events meeting to recruit more members.
One of the first pledges I made was to connect to the REACH network, and the REACH is the Race, Equality and Cultural Heritage Network, which is very well supported by our trust and by board. So connecting to them, having the space where people are encouraged and empowered to share some experiences that will help us to make us a more inclusive organization. So that's something I've been doing. And I also committed to taking part in stakeholder panels. Of course, recruiting the right personnel to support our trust in this activity is a very important function. And taking part in stakeholder panels is something that I committed and pledged, and I have done it. And I think that is really important, because it helps us as a trust to bring on board the right people with the right experience and the right values that fit in with our own trust values to come and support us.
Attending the Youth Advisory Board was one of my pledges, and I felt it was quite important to understand the needs and requirements of the younger people today, because they are tomorrow's future. So I found that quite an important pledge to do. One of the other ones was a governor at all relevant key events. I think it's key that governors should be seen and not just be a name or title. And by going to events and being seen gives us that opportunity to talk to the local people and to find out what they really expect from NHFT.
So what we learned from our previous experience was for us as governors to be a bit more measured in terms of what pledges we make, so that we're making realistic pledges that we can comfortably fulfill and not take on too much, and then find that actually we're struggling for time to be able to commit to those pledges. Yeah, at the providers event, I found it really useful. So it took place on the 9th of July. It was a Zoom meeting, and we were invited to showcase, good practice because we had applied. They had asked for applications from foundation trusts that felt they were doing something that others could learn from. So NHFT applied, and we were shortlisted and invited to come and present. And the reason we were invited is because I believe we did show through our application that we had a lot of good practice that we could share that others could learn from. And of course, we could also learn from others. So we were invited to share, and we shared mostly on our pledges. And we shared the pledges that other governors had made and how they had helped to make a difference to the way that we contributed as governors to the overall strategic objectives of the trust.
Excellent. Thank you so much to members of our Council of Governors for those videos, and hopefully colleagues who observed that were able to understand how governors work and the different things that they get involved in to help really support very effectively the governance of the organisation and the representation, the important role they play in representing members of our community. So it's a really important role, and you can find out more at various points in the year. We do run elections for governors. If you're interested in becoming a governor yourself, please do look at that link that's on the slide there, because it's a great opportunity to find out about that important role. And obviously members of staff can be governors when there are vacancies, and also members of the public, carers and patients. So thank you so much to our Council of Governors. As I mentioned earlier, they've also played an active part in designing this event, so I particularly want to show my appreciation to them for that as well. So we move on to the next item on our agenda. I want to take this opportunity to introduce David Ledger. David is one of our senior HR business partners, and as Angela mentioned earlier, we're working very, very closely in partnership, and I think I referenced it as well, with LPT, our colleagues in Leicestershire Partnership Trust. And one of the really important programmes of work that we do together is something called Together Against Racism. And I'm really delighted now to introduce David, who'll be telling us more about that. So over to you, David.
Thank you, Krishna, and good evening, everyone. And so our Together Against Racism work came out of feedback directly from our colleagues. Back in the aftermath of COVID-19 and the rise of Black Lives Matter, we were rightly challenged by colleagues on our approach as an organisation to advancing race equality. So we developed our approach, Together Against Racism, as a group, as referenced with Leicester Partnership, and co-produced that, really importantly, with our race, ethnicity and cultural heritage networks in both organisations. And we put behind the initiative corporate stakeholders, so HR, organisational development, comms and EDI, equality, diversity and inclusion, with the aim to move both organisations closer towards being anti-racism organisations. We had some early initiatives which started with really important board endorsements and commitment right from the top of both organisations. Those were cemented by board member anti-racism pledges, and we linked our board members up with members of our Reach network so they could talk through how they developed that pledge, what it would mean, and really importantly, how they would deliver it. We reviewed our decision-making groups and how inclusive our decision-making approach was, and we made inclusive leadership masterclasses available for all colleagues. Our early initiatives culminated in a joint board workshop. We explored what it meant to be anti-racist for both organisations, and how would we define that? What would our vision be? And how would we link that to our ambitions of continuing to provide a compassionate, caring culture, making sure we involve both our patients and our colleagues in our journey, and recognising that there are barriers to access of healthcare and also barriers to employment for colleagues from ethnic and cultural diverse communities. So at the start of 2024, we launched a new programme of work. We defined and recognised that our Together Against Racism approach was about acknowledging racism and discrimination existed. There was a commitment to take action, and all involved to challenge ourselves on unequal and discriminatory behaviours, structures, and attitudes. The vision was centred on working together to be places of care and work where everybody felt they could belong and bring their whole self. We moved much further than workforce at the start of 2024. We kept that as a key focus, but we also added in patients and service users and really wanted to get into our community and look at how we engage, how we have service users involved, and really importantly, how through strategy and partnerships, we can reach out into community and business and take this message from NHFT and LPT into our local communities. Some of the initiatives we put in place included workforce initiatives to look at inclusive recruitment and identified that as an area of focus. We developed new training course with our staff networks, and that led to an action plan to overhaul our recruitment process. We undertook further work to address racist incidents that our colleagues experience, unfortunately, from patients and carers, and worked in collaboration with Northamptonshire Police to bring stronger presence and commitment to addressing the concerns that are raised. We took steps to enhance career development and support for our colleagues from ethnic and cultural minority backgrounds. This included Talent Matters programmes that are running throughout this year, exclusively for colleagues from ethnic and cultural minority backgrounds. We also have in place career development workshops, which give people the opportunity to explore their career goals and work on getting the best they can to present themselves in those interview situations. In our patients and service users pillar, we've focused on implementing the patient and carer race equality framework, together in partnership with LPT. There are close linkages with our community pillar for the service user pillar, and the patient carer race equality framework links to everything we do. Leadership and governance to deliver race equality in mental health is fundamental, delivering better outcomes and experiences, and importantly, utilising the feedback from carers and governors to complete that loop of continual improvement. Co-learning is underway with patients from ethnic and culturally diverse communities, recognising the need for cultural competency across our organisation. Finally, the final pillar is community pillar. And within that, we establish standards for community engagement, service user involvement, and strategy and partnerships. Under each of those standards, gap analysis was completed, and that led to the development of our action plans. We've mapped community engagement and looked at where we've got some strengths, but also where we have areas of development. We've considered how we can increase ethnic and cultural minority research representation in our research and innovation, and working towards developing our social value approach. So again, taking our commitment to Together Against Racism out into the partnerships and organisations with whom we work, and increasing diversity in the assessment of key contracts and awards. Having a Together Against Racism approach was fundamental and vitally important as we responded to the civil unrest in early August 2024. It gave a clear commitment to how we'd compassionately respond to both patients and our colleagues. It helped us build allyship in the trust. And as we worked through listening events, a variety of listening events held with our reach networks, our trade unions, and our staffing groups, we identified the key areas in which we needed further focus. This was assessed against the NHS England guidance and the 8 key principles, and it helped us develop a new approach and new areas of focus. These include better communication of our Together Against Racism stance, so that all in our organisations are aware of where we are as trusts and where our priorities lie. A review of our policies and procedures, focusing on recruitment and our disciplinary process. How we're going to support our colleagues better to say no and address racism from our patients and carers. And finally, how do we train our managers in people processes and equip our colleagues in cultural competency so that we can deliver the place where people want to work and receive care and bring their whole self to work and the treatment that they receive. So thank you for this opportunity to share our work on Together Against Racism. Happy to take some questions at the end of the session. Thank you.
David, thank you so much for taking us through that really important programme of work. And whilst, we obviously wanted to be and are very clear about our commitment, we recognise there is a lot of work to be done, and David's really given you a really good flavour of that. If there are any questions that you want to ask about this programme of work, and indeed any of the other case studies or the previous case study that you heard about, and the governor work that we mentioned as well, just a reminder that you can go on to you can Google, if you weren't here at the beginning, you can go on to Slido. It's very easy to find. You can just Google it and then hashtag APMM 2024. And it's very easy to locate through that if you weren't here at the beginning. There might be a slide coming up with the QR code on that as well, but just in case you've missed that and you want to ask any questions, that will take you to the right place. Now, really pleased to move on to our next item, which is the annual report and account and quality account for 23-24. And actually, this is a sort of important formal bit of the agenda, which gives us an opportunity to explain a bit more about the financial performance of the organisation. And in that context, I'm delighted to invite our Chief Finance Officer, Paul Sheldon, to lead us through that. Over to you, Paul.
Thank you, Krishna. Good evening to everyone. As Krishna said, I'm Paul Sheldon. I'm the Chief Finance Officer here at NHFT. And I just want to run you through the highlights from the annual accounts, as Krishna has just mentioned. Whilst the financial year for 23-24 was incredibly difficult to navigate, it remained the commitment of NHFT board that safety is paramount for our staff and for our patients. And we're proud of the culture that has already been mentioned around compassion, and our commitment to care remains unwavered. The planned financial outturn, as agreed with NHS England for NHFT, was to deliver a £4.8 million deficit for the financial year for 23-24. The income for the trust rose from £325 million to £357 million. However, costs did continue to rise across all areas of the trust, notably from inflation around things like energy costs, but also through increases in the demand on our services. Our cash balance at the end of the year remained at 34 million, which in the context of many trusts around the country remains very healthy and will inevitably help us going forward. During last year, NHFT delivered £21.1 million worth of savings, which is approximately 6.1% of our overall turnover, which is a significant achievement through last financial year. That was mainly through reducing agency costs, the implementation of ongoing transformation schemes, and ensuring that the trust has all of the appropriate controls in place to be able to deliver that savings. And the agency that we spent last year of 10.4 million was considerably less than the previous years. Overall, NHFT spent £11.3 million on capital expenditure, and that involved investments in digital technology, estates and facilities, and included technical adjustments as well. Next slide, please. Looking forward, it's clear that, as we've seen with the change in government in recent months, there is unlikely to be an injection of significant finances into the NHS over the current financial year, or indeed, as has been highlighted, 2025 and going into 26 looks increasingly challenged from a financial perspective. So we're really in a position where we need to continue to innovate and deliver transformation. The financial plan for 24-25 is to break even. That is, of course, reliant on us delivering all of our savings plan as it was in previous years. And again, things like that will be around how we reduce how much is spent on overall on agency staff. What is key, though, as I've already mentioned, is around continuing that transformation of services so that we can work differently, but still deliver for patients and their families in that NHFT compassionate and inclusive way that has already been described. I'll stop at that point, Christian, and obviously there's a chance to ask any questions at the end.
Thank you very much, Paul. And I think we go straight on to Richard Anderson for a presentation from our external auditor. So over to you, Richard.
Thank you very much, and good evening, everyone. My name is Richard Anderson. I'm a director for Grant Thornton, and I am the Trust's External Audit Engagement Lead. And I'm just going to briefly talk about our audit findings for the 23-24 year across the three main areas of responsibilities for external auditors in the NHS, being to provide an opinion on the Trust's annual report and accounts, to provide a value for money conclusion opinion, and to consider use of any wider reporting powers. So if we can go on to the next slide, please. So in terms of the annual accounts, we issued a unqualified, which is a clean audit opinion, on the 20th of June 2024, and that was well in advance of the national NHS timetable for submission of accounts and annual report. And on the same day, we were able to close the audit for the 23-24 year. Positive audit findings. The Trust accounts were prepared to a high compliance standard and well supported by working papers from the finance team. In delivering audits of this size, you need to have a really good, strong collaborative kind of relationship with the finance team, and that was achieved through regular meetings, not just during the final accounts audit, but throughout the year. In terms of the work on the accounts, there were no adjustments during the final accounts audit that impacted the Trust's financial performance and position for the year. There was one unadjusted item which we reported, but because it was below the trust's materiality level, it did not impact our audit opinion. And there were some presentational adjustments agreed to improve overall compliance, and these were agreed and made. So overall on the accounts, it's a very positive message and a good outcome for the trust. If I could just move on to the next slide, please. So the second key area of my responsibilities as the trust external auditor is around value for money. And the work of external auditors in value for money considers the trust arrangements across 3 key areas, and they are financial sustainability, governance, and improving economy, efficiency and effectiveness in the use of resources, what we'd refer to as the 3 E's. And this work really considers service delivery, performance and outcomes. Value for money work is risk-based, and we do a lot of work to determine whether there were risks of significant weakness in arrangements, and I'm pleased to report that no significant weaknesses in arrangements were identified. As you might expect, the bulk of our focus in the value for money work this year was around the financial sustainability theme, and particularly the Trust's value programme and financial planning for the 24-25 year and beyond. So we did provide a good deal of challenge in that area. 4 improvement recommendations were raised, with 2 in relation to financial sustainability, and 1 around in governance and 1 in the improving economy, efficiency and effectiveness area. The improvement recommendations were discussed and agreed with the trust and reported in our audit findings and our auditor's annual report, which was presented to the board in June. So 4 improvement recommendations were raised, but in terms of give a bit of perspective and context, that's a relatively small number of improvement recommendations that you'd see on a trust of this side. So again, a positive outcome for the trust from the value for money work. And then just to touch on the third area of responsibilities for external auditors, there's a range of wider reporting powers which could be used, and I'm again pleased to report that it was not necessary for me to make use of any of those reporting powers in the 23-24 financial year. So that's a high level summary of our audit work across those 3 areas of responsibility, and very happy to take any specific questions on our work in the question section at the end. But that's all from me. So thank you very much.
Thank you very much, Richard, and thank you again to Paul as well earlier. So really important because again, you're hearing from our external auditor in terms of our sort of accountability for governance, and actually worth noting that the external auditor is appointed by our Council of Governors, so it's part of the responsibility of the council to make sure we've got a sort of that external auditor assurance kind of available, and what you've heard from Richard hopefully will give you colleagues and stakeholders a degree of assurance and comfort that we have some good controls in place, albeit with some improvement recommendations raised, which we obviously will take forward. So thank you very much to Richard and to Paul. Last but not least, well, just a quick reminder actually before I bring in our final case study of the evening, that there is still an opportunity to ask any outstanding questions that you'd like to raise, and certainly particularly in the presentation that Paul and Richard just did. Just a reminder, it's the Slido is the website, and hashtag APMM 2024 will get you to the right place to be able to submit a question if you'd like to. The questions will close after this case study. And we'll certainly try and answer as many as we can and as quickly as we can. We've had a fair few already, so we'll do our best. But obviously, if there's anything we haven't been able to answer, we will take them away and try and respond to them if we can to individuals who've raised them. So without any further ado, I'm delighted to introduce the case study 3, which is about our memory assessment service within NHFT. And I'm really pleased to introduce a couple of colleagues I know pretty well, Dawn and Nancy. Over to you, Dawn and Nancy, for your presentation.
Thanks, Krishni. Can we have the next slide, please? Nancy, do you want to hand over to this bit?
Yeah, thank you, Krishni. Good evening, everyone. Thank you for being here today. So my name is Nancy Gatawa. I'm the operations manager for the Rushden team, older people community mental health team, including the memory assessment service. We're really excited to be here today and to be given the opportunity to share with you what memory assessment service is and the new ways of working that we've implemented in our memory assessment service. So before we dive into details, I'd like to just acknowledge the hard work and collaboration that has brought us to this point today. So we're just going to explain how these changes have improved patient care, reduced waiting times, and made a positive impact on both our team and the people that we serve. So who is Memory Assessment Service? Memory Assessment Service operates across 4 counties. We have 4 teams in total, 2 in the north, Corby and Rushden, and 2 in the south, Daventry and Northampton. We're serving the whole entire county. So we provide services from Monday to Friday, 9 a.m. to 5 p.m. Most of our referrals, they come through our GPs, and who provide us with a 6 months history of progressive memory impairment, and along with necessary physical health checks, including dementia blood screening and baseline cognitive assessments. So upon receiving a referral, it is screened by a nurse and discussed in our multidisciplinary team. This team includes a consultant psychiatrist, occupational therapist, psychologist, mental health nurses, support workers, and peer support workers. Following this, the patient and their family are invited to the clinic or offered a home visit for a comprehensive assessment. So based on the assessment, further tests such as scans may be requested depending on the presentation of the memory impairment. If a diagnosis is made and medications, there will be medications that we can offer if patients are suitable. So we call them cognitive enhancers. We will trial this for 3 months, and if patient responds well and there are no side effects, they're discharged back to their GP with ongoing post-diagnostic support. Our services also offer group interventions such as the Living Well with Dementia group, cognitive stimulation therapy, and next steps workshop. We also work very closely with our partners, Alzheimer's Society, to provide further diagnostic support. So I'll just hand you over to Dawn, who will talk a little bit about the service opportunities and challenges.
Thanks, Nancy. Next slide, please. Good evening, everyone. I am Dawn Rosen. I'm the Head of Service for Old People's Mental Health Services. And as we've already said, within the Memory Assessment Services, we have faced a number of challenges as a service coming out of COVID, linked to high referral numbers and long waiting lists. However, these challenges have actually given us an opportunity to look at different ways of working. I am going to hand you back to Nancy in a minute, and she will explain to you how we've reviewed the way we worked. And within this opportunity, it's helped us reduce our waiting lists, the time between assessment and diagnosis, and reduce the number of crisis calls that we've had from people on the waiting list. So Nancy, if you just want to explain that new ways of working.
Yeah. Okay, so just to address the long waiting list that we encountered during COVID and post-COVID, we introduced a new one-stop shop model, this streamlining our patient journey. Previously, patients would need to attend multiple appointments for assessment, diagnosis, and then treatment. However, now on a designated day each week, patients receive all the services in a single visit. So in this new process, patients first undergo memory assessments conducted by nurses mainly. Then patients would have come with their scans already before the assessments. And then following this assessment from a nurse, the nurse will meet with the consultant psychiatrist who will discuss the results of the assessment and possibly provide a same-day diagnosis in most cases. So while patients wait, they are offered physical health checks by our support workers. And once these are completed, they return to the consultant for diagnosis, disclosure, and if appropriate, treatment is discussed and initiated during the same appointment. So this new approach has significantly reduced our waiting times, with patients and carers appreciating the convenience of fewer appointments and efficiency of receiving their care in one day. So I'll just hand over to Dawn again.
Within this as well, following on, it's given us further opportunities to improve the way we work with the Alzheimer's Society. As partners, we work together with all people under the Memory Assessment Service, and the Alzheimer's Society will contact everyone pre-diagnosis and post-diagnosis to offer signposting and ongoing support. We've also currently been working with Kettering General Hospital to improve our scanning wait times for people under the Memory Assessment Service. The aim is that people will wait only 2 weeks for a scanning appointment. This is at early stages though at the moment, but we have further plans to extend this work within Northampton General Hospital in the very near future. Nancy, I'll just hand back to you about some patient feedback, and if we can have the next slide, please.
Yeah, thank you. Okay, so we collected some feedback from our patients whilst we were conducting the one-stop shop as a trial, as a project to start off with. And the feedback was quite encouraging. Patients felt supported and listened to. And, you know, in the mantra of you said and we did, that's exactly what we did. The family say they felt happy to be seen and left with a diagnosis. There was a lot of gratitude, and they said the nurses and the consultant psychiatrist were very compassionate. They were happy to be seen in a timely manner, and it made a significant difference in reducing risks in crisis. There was a smooth transition from diagnosis to post-diagnostic support. It was seamless, it saved time. One patient sort of said initially they thought it would be a hectic day, but this was not the case and it ran smoothly. And they preferred the way of working that we're currently doing. Over to you, Dawn.
Thank you. Next slide, please. To end the presentation, I'd just like to share 2 more pieces of patient and carers feedback. The first one is a patient's poem. It was written by a patient who shared it with her memory assessment nurse. She told the nurse that she used to work in a care home and would provide reminiscence sessions to the residents in the home. And she wrote the poem and shared it during one of the sessions when she worked. She wanted to share it with our memory assessment services, and she gave permission to share it today. So I'll just read the poem. She smiles as she dozes in a chair by the bed, and I wonder what thoughts are going round in her head. Her mind travels back and she's young once again. With her man by her side, she walks down the lane to the home where they shared all their joys and pain. The children she held so close to her breast are all gone now and put to the test. She remembers her son, so young and strong. He marched off to war. He never returned, and the time seems so long. This woman whose body now withered with age, who awaits for a soul to escape from its cage, sitting so still in her chair by the bed, but she still has her memories going round in her head. And then just the last picture, next slide. I just wanted to share the next slide. As Nancy said, we do Living Well with Dementia groups, post-diagnostic support for patients and the carers. And on the back, this group of individuals actually meet separately and go out for lunch. And their second lunch meeting together, they sent a picture of themselves to the workers who deliver the groups, just saying, promoting the effectiveness of the course gives us confidence and equips us with the tools for future opportunity to keep in touch for mutual support. So we just kind of wanted to end on that. And that's it. Krishni, back to you.
Brilliant. Thank you very much. And you can see there's lots of virtual applause and popping up and feedback really about that beautiful poem as well, which is really touching. It's great, you know, we again, similar to the story we heard from our CAM service, we had the privilege of hearing from Nancy and other colleagues about the improvement work they've done across the service at our board meeting earlier in the year. And it's great to be able to share that really with other colleagues who may not have heard that story and the sort of broader themes arising from that. So thank you very much, Nancy and Dawn. And hopefully what you've heard from our two case studies is a sort of illustration of the different ways in which we work. And if you remember, the theme of this event was making a difference across generations. So we've heard a bit about our CAM service and we've now heard about an older adult service. And you can see the type of touch points that we as an organisation do have with our community. And I know we're all very proud of the work that our staff do, recognising that there's always more that we're trying to do to improve as well. So without further ado, we now move on to our question and answer session. We have certainly received a number of questions already. I think I mentioned at the beginning that there were a number that we received before the session opened today. So we're going to try and address as many of those as we can over the next 20 minutes or so. And I will be bringing in colleagues who to answer those questions as well as I can. So first and foremost, there are a couple of comments there, but what services? So we can see the questions there. I think the first, if we take them in turn, what services are available for autistic adults and those diagnosed with the mental health condition? Now, I'm not sure who's going to answer. Is it Anne? I think
me,
is going
yes.
to do that. Yes, sorry, Anne. There you go. Bring you in.
Thank you, Krishni. Hi, my name's Anne Rackham. I'm Chief Operating Officer. And so this question it's got a lot in it because employment's so important for so many of us, giving us structure, linking us into our community, and that's really recognised particularly in the mental health field as well, and also how important this is for people's recovery. So we have a number of ways where we reach into sort of looking at employment. One of those is through our IPS service, our individual placement service, which support service, which is about meeting people where they are in their journey and looking at what their aspirations are, what their training's been, what their experiences are, and linking them up and supporting them, acknowledging their specific needs at that time or their specific needs through any neurodiversity, and working with employers to help that path and passageway into employment. We also have employment advisors within our IAPT service, our talking therapist service, which is really important that we've got a whole range of people who can access specialist support. And part of the work we do through those advisors is linking to our job centre, so that we're really connecting into the key agencies in our community to support people to get back to work.
Thank you, Anne. There's hopefully a very comprehensive answer for people there. So we'll take the next on the list. And for this one, I'd like to bring in Dave Mayer, please.
Thanks, Krishni, and hello all. So just regarding CYP, children and young people, autism and ADHD, we are in the process of implementing a new model, which is a same-day assessment model, which is intended to increase assessments for this population group. We've also seen huge growth across the country and locally with ASD and ADHD, and that's encouraged NHS nationally to establish a clinically led review group, which is yet to report in terms of the public health and general NHS approach for people with ASD and ADHD. And similarly, our local authorities, as a partnership, we've just gone through special education need assessments for both North and West. And it's fair to say ASD and ADHD is one of the 4 priority action areas for us as a partnership to mitigate the demand that we're seeing. So we're expecting to see our local ICB complete a paediatric review in October, which will cover the model of care expected for ASD and ADHD across the county, to include NGH, who are also part of the pathway. But a very live issue, and the national picture, I think, will need to conclude as part of the long-term plan, which I'll cover later on in one of the questions.
Thank you very much, Dave. Okay, we move on to the next question then, which, as you can see, is one around crisis cafes. So I'd like to bring in Anne again, and in case people don't realise, is our Chief Operating Officer. Back to you, Anne.
Thank you, Krishni. Yes, so our crisis cafes are managed in conjunction with Mind. It's really a key part of our crisis pathway, and how we work in our mental health, learning disabilities and autism collaborative. So we will have times when we have to work together across the sector with Mind and ourselves about how we best staff things in times of sickness, etc., or something happens. But what's the joy of the collaborative is how we do that together. It gives us a wider pool to be able to use our resources in the most optimum place at any one time. So we don't like to have any times when our cafes are closed, and we really work hard for that never to happen. But if it does, we work together to look at how we can get the best response in crisis at that time.
Okay, thank you very much. Moving on then, I'm going to focus on the one that relates to an NHS dentist, because that was the one that came in, one of the ones that came in before the event. So David Williams, please, for that one.
Thank you, Krishni. Good evening, everybody. I'm David Williams, Group Director of Strategy and Partnerships. And thanks very much for the question. I think we provide care in lots of different locations. So I think over 100 different locations around the county, in GP premises, family hubs and other things. So I can understand why people would want care as close as they can. In terms of dentistry, it's part of the primary care services that are decided, along with pharmacy and optometry, that are decided by Northamptonshire Integrated Care Board. And although Brackley is a healthcare centre operated by us, the decisions of which services need to go in it and where they would like them based for dentistry need to be made by Northamptonshire Integrated Care Board. So it would be a question to direct towards them for their answer about where they want dental services locally.
And David, whilst you're sort of in the hot seat, if that's the term I can use, there's also a question about an opportunity to partner with the external businesses that support mental health and wellbeing locally. Are you able to respond to that?
Yes, by all means. So thank you. If that is an opportunity of a business that wants to talk to us, that thinks we could do more about supporting mental health and wellbeing, then please do get in contact with me. Be really interested. Part of the work that we're doing and the key part of our strategy is about developing in partnership. So Anne's just talked recently about the work we do with Mind. We work with a whole host of different voluntary and community organisations, universities and other providers. Very, very keen to see how we can be an anchor institution making a difference across the county of Northamptonshire. So if there's anything there that you would like to talk through or an idea, please do get in contact. Be happy to talk it through.
Okay, thank you very much. We have a question about children still being sent out of county when requiring mental health treatment. And I think Paul Sheldon's going to respond to that.
Yeah, thank you, Krishni. Thank you for the question. I think one of the things with with CAMS inpatient services is the changes made over the last couple of years mean that actually there are very few children that are being sent out of county for mental health treatment. The vast majority are dealt with by NHFT and partners within Northamptonshire. There are on occasion very real reasons why children do need to be sent out of county. That might be for safeguarding reasons. That might be because the level of provision, the level of care that they need is just so specialist that actually there are very few places in the country that can deliver that care. So that's why, on the very rare occasion that those circumstances turn up, that's why people are then sent out of county for their treatment.
Okay, thank you very much. Next, what is the consequences for staff members found engaging in racist behaviour? Just wonder if David Ledger could respond to that, please.
Yeah, thank you, Krishni. So as an organisation, we have a range of policies and procedures that set out the expected behaviour and standards of colleagues. And if colleagues unfortunately fail in that, in kind of meeting those behaviours and standards, then we have HR processes and policies to look into that in much further detail. We have a clear stance that racist behaviour won't be tolerated in the organisation, and consequences will follow for colleagues who engage in such behaviour.
Thank you very much, David, and really important question. I think we'll take NHFT plans around health and equalities. David Mayer, are you able to take that?
Yeah, can do, Krishni. Really appreciate the question, not least because we've got a 10-year plan process ahead of us. We've got a programme looking at health inequalities through three lenses. One is access, so making sure services are local to need, and that really speaks to our model of care as an NHS provider working in local communities in partnership throughout both parts of the county, in North and West, and with our local area partnerships. So access is pretty fundamental. The other relates to outcomes, so understanding where we've got variation in outcomes, and that requires us to understand our data really well. So we know that our poorest neighbourhoods will live 17 years with a disability. We know equally where we've got entrenched inner city locations or inner town locations, we see a different presentation in terms of mental health needs. So data is pretty critical to understanding how we improve outcomes. And then the third bit relates to experience, and that includes some of the work that we've described in Together Against Racism, because in many ways that programme for our staff and for our teams is as much about rooting out inequalities as it is about experience for staff working in the organisation. And equally, we will be focusing on our waiting lists, as the entire NHS is, really, to understand needs within those waiting lists and making sure that we're meeting need appropriate to the presentation of the individual and relevant to the context within which they live. So 3 strands.
Great, Dave, thank you very much. Really helpful response there. So the next one I can see on the list is there's a question for Marie, family ambassadors question. Marie, are you happy to answer that?
Yes, I didn't read it as a question. I think it says they're able to support parents and carers with hope and signposting with emotional struggles, and that they do work closely with the wards, which I absolutely acknowledge. That is a fantastic service for our families and especially our parents and carers. We also have carer peer support workers that support our families too. So yeah, hugely valuable service.
Great, thank you very much. And David, is there anything that you wanted to add to that?
I think there was a separate question that came in that just wanted a little bit more information. I think Marie's done a really good job on answering it. And I think the whole point about family ambassadors is that a difficult time when the NHS is using medical terminology, understanding things, thinking about different things, anything we can do that helps bring the care together is a really important thing, because it helps people get back to where they are very quickly with the right support. So nothing more than that I've just added.
Great. Thank you very much, David, and thank you, Marie, for responding to that comment. So the next one I can see that I think we might have had before the event started, I think, is an interest in joining the NHS and this organisation and contributing to our mission, which sounds amazing and fantastic. David Ledger, please, if you can make a comment about that in the process.
Yes, firstly, thank you for the interest in joining Team NHFT. And there's a wide range of career opportunities available, from working in clinical roles, delivering compassionate care, to support roles and supporting patients and our staff members. We also have opportunities for people to get involved as volunteers and also to join us on apprenticeship programs. So all our opportunities are advertised on the NHFT website, where you'll find comprehensive breakdowns of roles available, how to apply, and where to find further information.
Great, thank you, David. And what I would like to just briefly plug is we've got a webinar taking place on the 2nd of October, Careers in the NHS, which you can just look up. It's a free webinar, and you can look for it under our membership section of our website, and you can sign up for that. Thank you very much. So the next one is a comment, but also a question about the sequin for pressure ulcer screening in community hospitals being only partly achieved. And I'd be very pleased if Linda Chibuzzo, our chief nurse, is able to respond to that.
Thank you, Krishni, and good evening, everyone. I'm Linda Chibuzzo, I'm the chief nurse, and thank you for the comment and question and the recognition that we have made progress with regards to our sequence for last year and certainly our quality priorities. We made a lot of progress last year, and why we then said we partially achieved it is because we had not yet completed the audit. Various things were put into place in order for us to improve patient care and reduce our pressure ulcers, where we developed a new template for the nursing team to use, which we then uploaded onto System 1 last year. And this brought about the whole assessment into one place. So previously, clinicians were putting information into different areas, but this brought it into one place and also included a dedicated section to get the patient voice and also get the input of the carer. Our matrons then arranged to appoint sequin leads who are meeting regularly to update on the progress. And certainly there were then wound routes that were created, set up to review patients and actually have the patient's case managed, looked after by one practitioner who followed their journey through, whilst ensuring that reviews were done in a timely manner, updating templates and risk assessments. So that in itself led to positive outcomes for patients. And where patients were waiting to be examined, again, there were regular reviews, board rounds where matrons were involved and ensured that no patient was missed and any actions were followed through. Our pressure ulcers are a quality priority, and certainly for last year, we're pleased to report that we were able to clear our backlog of pressure ulcer reports that have been raised on our Datix incident reporting system. So we managed to do that. But what's key from doing that was us learning and recognizing that we can put more into preventative actions. So this year we set up a pressure ulcer harm review group, which I lead, and that group meets fortnightly, where we're proactively reviewing all new grade 3, grade 4 pressure ulcers with the focus to preventing harm and ensuring that we're learning. This group is meeting in a timely manner, and any learning is shared across the organization with relevant colleagues. It also has really good engagement from practitioners and welcomes and certainly puts at the core the voice of the patient carer, so that we are continuously learning and preventing harm. Thank you very much.
Thank you, Linda. And I think that one of the comments also just links to that, which hopefully I think Linda's already covered off. So I'm going to go to the question about the crisis response unit. There were a whole series of questions about mental health services and yes, quite a lot of detailed questions, which we probably won't be able to cover tonight, but we will make sure we'll respond to those separately. But certainly the question about crisis response units, I think we can go to Anne Rackham again for a response on that. Over to you, Anne.
Thank you, Krishni. We have one crisis response unit in the county that's just had its first birthday, which was very exciting. And it's been a really great first year in trying to make a difference in how people experience crisis support for this county. This has not been done just as an alone thing. This is part of the crisis pathway, but it's very much linked into the EMAS control room, where there are mental health professionals as well. So there's a lot of contact with the control room to really help as early as possible in the care that we provide. So we had 3,236 contacts with EMAS within that year to help with thinking about what the care plan should be for somebody, how we could strategically support and get people to the right services. The unit itself was deployed 816 times across the year. 729 of those were within 1 hour, which is a phenomenal response that we have been really keen to achieve. That was our plan in the first place, and it's really great to see that working for so many people. As the people that we deployed to, 733 were avoided admissions to the emergency departments in the acute hospitals. So a massive response for the urgent care pathway across the system. So really great to see the crisis response unit celebrating their first year and to really learn and build on the successes they've had.
Brilliant. Thank you very much, Anne. And I think we heard about the crisis response unit in our previous in our AGM a year ago. So it's great to kind of get an update on that and have the opportunity. So thank you for the question that enabled that. I'm really conscious now that we are rapidly running out of time for our event. So I'm going to try and take a couple of maybe quick fire questions before we close. So perhaps take the next couple. Important question, David Ledger, about EDI being factored into our job descriptions, etc. So I wonder if you could make a brief response to that.
Yes, certainly. Our job descriptions are focused on recruiting for values. We recognise that it's so important when it comes to patient care that we get our staff members with the right values at the right time to provide the right care. And certainly the work we're undertaking at the moment is debiasing processes, and that has a big part to play when it comes to job descriptions and assessment on the track recruitment system.
Okay, thank you, David. Really helpful. And Paul Sheldon, please, a response on the sort of risk sharing given the partnerships and group arrangements.
Yeah, thank you, Krishni, and thank you for the question. I think certainly as far as the group arrangement with NHFT and Leicester Partnership Trust is concerned, both trusts remain accountable for their own money in their own system, and they're both statutory bodies, so that will remain as it is. Interestingly, as the system evolves, we are all still getting used to the fact that we operate now in a system control total with the local integrated care board, as well as Kettering General and with Northamptonshire General Hospitals, all of which are statutory bodies. But there is now a duty within our financial regime that we contribute together to deliver a balanced position across the system. So I obviously, Krishni, I could go on, but in the essence of the quick fire questions, I'll leave it there.
Thank you very much. Thank you, Paul. And I think the question on being referred to MAS, is that for Nancy or Dawn, perhaps? How would a patient be referred to MAS?
Krishni, they would go to their GP and ask the GP to refer them to MAS.
Okay, lovely. Thank you very much, Dawn. Okay, final question then, and an important one, really about balancing the demand on services with sort of financial challenges, etc. So our Deputy Chief Executive and MD, Dave Mayer, I think, can respond to this.
Thanks, Krishni. A really important question, so thanks to the individual who asked it. I think fair to say we are focused on our value program internally, and that's value across the spectrum and ensuring services are safe. There is a question in the long-term plan process, which Lord Darcy has kicked off with his review, and which certainly seems to be politically kind of pertinent in relation to shifting of resources to primary and community care services. So our hope is that some of the answer to the question will sit in the long-term plan process in terms of articulating a way that the balance of investment across the NHS will begin to move increasingly towards those settings of care, such as community services. The 10-year plan, we have got some information on our website, a little summary of the 10-year plan, and increasingly throughout the year we'll use that placeholder to update people in terms of how our work is going in terms of managing this. I do just specifically want to mention staff burnout and turnover of staff. We have got quite a robust wellbeing steering group in place across the trust, with non-executives included, looking specifically at our wellbeing offer to teams. We know we did some good work after COVID with dedicated time out for teams to reflect and reconnect as individuals and as teams, and we want to build on that by having a consistent process with teams and ensuring their managers are supported in terms of workload and taking time out appropriately to reset and reconvene as teams across the trust. So burnout and consideration of that is top of our mind, and the people dimension of the long-term plan is one I think as a system will play a strong role in beginning to shape for the future. So thanks again for that question.
Thank you very much, Dave. I am reminded that there was a question we received on our racism strategy, I think via email. So Richard Smith, do you want to just give us a quick précis of that question, and we'll get a response from David Ledger?
Thanks, Krishna. Yes, just to do 2 points actually. So briefly to reflect on what you were saying earlier, we had a series of quite detailed questions concerning children and young people's mental health. We will be picking those up with the individuals that asked them after the meeting. And then the other question that we received in via email relates to the racism strategy. And I'm just finding the question here in my chat. It comes from one of our colleagues over at Kettering General Hospital, one of our governors there. Here we are. So how can you assure me that what views expressed relating to the consultation on racism strategy will be taken on board and implemented, in particular the health inequality and race inequality elements?
David Ledger, are you happy to comment on that? I think this particularly related to the Mental Health and Learning Disability Collaborative, didn't it? So
That's right.
Is that right?
Yeah, I think it's a vital piece of work, community engagement work, that was undertaken by Northamptonshire Black Communities Together. And I think that partnership with that organisation really reaches out into our community and will play an important part in engagement and sharing those views and feedback. And that engagement will underpin our approach to reducing health inequalities in mental health by co-learning and by putting in initiatives that work directly for those communities that need it the most. I think the specifics in that report have been considered and taken forward in the Mental Health, Learning Disability and Autism Collaborative.
Excellent. Thank you very much, David. Now, in the interest of time, I do need to bring that to a close, but really important that we'd love to get your feedback, please, and on tonight's event. And if you could share your views and thoughts using Slido as before, We would really value that. I think there are 2 questions if you actually scan that code. How would you rate this event? What 1 or 2 words describe the impact of this event for you? And also indeed the opportunity to provide any comments about future events. So if you could share your views on that, we'd be extremely grateful. And indeed, I think, Richard, are we going to be sending out a separate evaluation as well, in case people don't use Slido?
Indeed, Christian, yes. So we'll follow up after the event with a link for people as well. Yes.
Okay, lovely. All right, so thank you really incredibly, first of all, to everyone who's been involved in organising this event, and all the contributors as well who've presented today, particularly David and Dawn and Nancy and Marie, who did our case studies, and also our governors for the video that they developed, and of course our auditors as well as our executive colleagues. And do you want to move on to the final slide? So there's some results being shared, I think, from the feedback that people have given. So I don't know whether, Matt, did you want to flick back to that briefly? Okay, so we're getting some positive feedback, so really good to know, and please do keep sharing that, because I can see that people are responding. I think there was a word cloud developing about which was nice to see as well. Oh, we've lost the login there, but we will absolutely collect all that feedback, and thank you so much for sharing it. But in the interest of time, I just really want to, as I was starting to do, just thank everybody for their contributions. Thank you all for all your questions, which were really fantastic and gave us pause for thought as well. Hopefully we've answered them as well as we can, but we will absolutely, if we haven't covered them all off, we will be responding to people individually if you submitted them on email, for example. A reminder again that the Careers in the NHS webinar is on the 2nd of October. That's our next public event. It's a free webinar encouraging you to come and join our wonderful NHS and make a contribution and make a difference to our communities. And thank you so much for taking the time to join us this evening. And don't forget, this is available to watch after the event if anyone wants to catch up on it. Thanks again. Thanks, everybody. Good night.
Thanks, Krishni. Thanks, everyone.
Thank you. Thank you.